ஹலோ சுரேஷ், உங்க ஆடியோ மியூட்ல இருக்கு.
Only can you try your slides? Start sharing and see whether it's moving or not.
Good evening. Am I audible?
Yeah, you're audible only. Just show your slides whether it's moving. Just check. Okay, just try your slides. Start sharing and see
சுரேஷ்,
whether.
உங்க வாய்ஸ் ஆடிபிளா இல்ல. ஆடியோ கேட்கல.
You just start sharing your slides and check whether it's moving. இப்ப கேக்குதா? Can you hear me now?
எனக்கு கேக்குதா?
Hey, I'm hearing you. 1 second, I'll just.
Am I audible? Okay, your voice is not audible. மியூட்ல இருக்கீங்க. மியூட். Still muted.
Can you hear me now,
உங்களுக்கு
Murli?
அன்மியூட் பண்ணிட்டாங்கன்னு நினைக்கிறேன்.
Yeah, can you hear me now? இப்ப கேக்குதா?
இல்ல.
Now you are able to hear me, Murli? Hello? Hello?
Yes, sir, we are able to hear.
You are able to hear. Good.
Yes.
You make both Dr. Murli as well as myself to start sharing screens as well as audio and video on there. Okay. IT team, please ensure both Dr. Murli and myself to both share video as well as audio.
உங்க வாய்ஸ் எனக்கு வரவே இல்லை எதுவுமே. Just check whether others are able to hear you.
Others are hearing, Murli. Yeah, others are hearing. That's what. Anybody is hearing me? Hello? Hello?
Okay.
You're able to hear me now?
Yes.
Good. So you just start sharing your screens and just check whether slides are moving. We got 5 more minutes.
I already tried.
Okay, that's fine. That's no issue. It's fine. We start sharp by 7:30 Murli.
Am I clearly audible?
Your voice is clear. Good evening, one and all. We are starting this session on short certificate course of infectious diseases for postgraduates and residents. And I sincerely thank API as well as ICP for providing this wonderful opportunity. And I also thank the speaker for today because in short notice, Dr. Murli agreed for this one despite busy schedule. Today morning, he has got a very busy schedule in the morning. But despite the schedule, Dr. Murli agreed for the talk. Dr. Murli does not know any introductions. He's a professor of medicine at PSG College in Coimbatore, and he's a well-known speaker. And he's going to discuss today community-acquired pneumonia, how to approach for practical reasons, because community-acquired pneumonia is one of the common cause in OP as well as IP setting as well as in ICU settings. So he's going to discuss next 30 to 40 minutes how to approach community-acquired pneumonia in your busy practice. And you please note down whatever questions, please put it in the chat box so we can interact at the end of the presentations of Dr. Murli. Whatever Q&A, please go ahead and put it in the chat box. I think Dr. Kamlesh Tiwari sir has not joined today. Hope he is joining during the presentations. Without further wasting our time, I ask Dr. Murli to start his presentations, and I sincerely thank one more time for agreeing our invitations and joining today. Yes, Dr. Murli, the stage is yours.
Yeah, thank you. Thank you, Dr. Suresh, for inviting me. Let me share the slides.
Okay.
Perfect.
Okay. Yeah, very good evening. Today I'll be discussing about community-acquired pneumonia. Let's start with the case. 75-year-old male present to the emergency with altered sensorium since the morning of on the day of presentation. Wife said he had some cough with the expectation for the past 3 days. Fever 1 day, high grade. There are no chills and rigors. There are no, I mean, he had some, there are no case of upper respiratory symptoms. Sputum was yellowish white, minimal in quantity, was no hemoptysis. Slightly breathless on the 1 day prior to the admission. There was no arthralgia, myalgia. He is from Chennai, working as a lawyer, living with his wife. Recent traveled to Bangalore for a day, came back, attended a marriage and came back. No history of allergy, no pets, no blood transfusion in the recent past. There was no weight loss, no loss of appetite. Wife is healthy, doesn't have any symptoms. There was no history of pulmonary tuberculosis or a contact with the tuberculosis patient. There was no history of vaccination in the recent past. Clinical examination, he was tachycardic, had a hypertension which required minimal noradrenaline support. On presentation, he had a hypoxia, improved with O2 supplementation, roughly 2 to 4 liters of O2, slightly drowsy, and the respiratory system showed left infrascapular crepitations. If you look at the differential diagnosis at this point, if it is an interactive class, probably I could have asked you. Anything could be possible here. Drowsy, plus had a lung signs, could be a CBA, hypoglycemia, aspiration, could be a pneumonia. So the initial investigations, neutrophilic leukocytosis, platelets were 2.5 lakhs, yes or 45, RFT left in normal, urine didn't show any pus cells, blood and urine cultures were sent. This is the X-ray, which showed that left mid and lower zone dense opacities. So obviously it's a pneumonia. The blood culture, gram strain showed a gram positive cocci, and the culture grew alpha hemolytic streptococci. A gram stain which showed 10 to 12 pus cells, 15 epithelial cells. There were a lot of GPCs and many GNBs in the sputum. The culture grew multi-drug resistant Klebsiella pneumoniae. So what is the diagnosis here? Is it a pneumococcal pneumonia, or it's a Klebsiella pneumonia causing pneumonia? It's basically a bacterial pneumococcal pneumonia. Should remember the Bartlett scoring system. It based on the neutrophils and the epithelial cells. If there is a less than 10 neutrophils, score is 0. If more than 25 neutrophils, score is 2. Epithelial cells 10 to 25 score is -1, whereas more than 25 is -2. So total 0 or less indicates lack of inflammation, and probably it's not a proper sputum sample to culture. The lab, the microbiology lab should reject the sample and ask for a fresh sample. So that is very, very important when you do a sputum culture. So what is pneumonia? Pneumonia refers to a syndrome caused by infection characterized by clinical and or radiographic signs of consolidation of a part or parts of one or both lungs. Look at the epidemiology, roughly 10 per 1,000 population, fifth leading cause of death. Mortality can be as high as 50%. More common in both extremes of age during winter months. In India, the rise in pneumonia cases is also noted during after the monsoon also. The largest decrease in the incidence of pneumonia over the last 30 years has been in the infant population because of the vaccination. Pneumonia is the most common hospital-acquired infection, accounting for a death of frequency of around 0.5 to 5% of the admissions. We can classify pneumonia by anatomy, pathogen, by the acquired environment. So what we are dealing is the classification by the acquired environment. We will be dealing with the community-acquired pneumonia. So what is a CAP? It's an acute infection of the pulmonary parenchyma that is associated with some symptoms of acute infection accompanied by the presence of acute infiltrate on a chest radiograph or osculatory findings consistent with the pneumonia in a patient not hospitalized or residing in a long-term care facility for more than 14 days prior to the onset of symptoms. This is the definition of community-acquired pneumonia. There are two types. Classical CAP, other one is the atypical CAP. Classical CAP, sudden onset of CAP presenting with a high-grade fever, chills. A patient will have pleuritic chest pain, they will have breathing difficulty, they will have a productive cough, rusty sputum, sometimes blood-tinged sputum. Patient will be sicker. The mortality is high, as much as 20% in patients with bacteremia. Most common organism is the pneumococcus or strep pneumoniae. The other one is the atypical, which is a gradual or insidious onset of CAP. Patient will have a low-grade fever, can have a dry cough, no hemoptysis. Generally, they will be good, otherwise called as a walking CAP. Mortality is low, roughly 1 to 2%, higher in legionellosis, whereas the causative organisms here will be Mycoplasma, Chlamydia, Legionella, Rickettsia, and viruses. What are the risk factors for CAP? One, age, obesity, smoking, alcoholism, the pre-existing asthma, COPD, immunosuppressed conditions, coexisting HIV infection, old age homes or residing in a long-term care facility, and dementia. If you look at the pathologic or organisms isolated for pneumonia or a CAP, most common is the strep pneumoniae. Roughly more than 50% isolated organism was strep pneumoniae. Then comes your H. influenzae, then Chlamydia, Legionella, etc. Viruses constitute a smaller percent, roughly 9% of the community-acquired pneumonia. If you look at the organisms by the site of care, for outpatient pneumonia, most common organism is Streptococcus pneumoniae, whereas next would be the Mycoplasma, next is the Haemophilus, then Chlamydophila, then the respiratory viruses. Whereas in patient hospitalized but not in ICU, again, pneumococcus is the first pathogen. Next comes the Mycoplasma, then Chlamydia, H. influenza, Legionella, and viruses. Whereas the patient is sicker patient in ICU, still pneumococcus is the common organism. Next comes the Staph aureus, then the Legionella, gram negatives, and the H. influenzae. So, irrespective of the site of care, whether outpatients, non-ICU or ICU, pneumococcus is the most common pathogen causing CAP. If you look at the comorbid conditions and try to find out what could be the possible organisms, in an alcoholic patient, strep pneumococcus, oral anaerobes, COPD or smoking, H. influenzae, Pseudomonas, Legionella, Then somebody who has got a structural lung disease, Pseudomonas, Burkholderia, Staph aureus, dementia, stroke, somebody who is unconscious or drowsy. Then oral anaerobes is a common cause. Next comes the gram-negative enteric bacteria. Less than 25 years, Mycoplasma, Chlamydia, whereas more than 60 years, pneumococcus. Patient with diabetes, second pneumococcus. Exposure to contaminated air conditioning, cooling towers or mist or machine, then it's Legionella. Exposure to bat, caves, excavation, then histoplasmosis. Exposure to rodents or water contaminated by animal urine, then leptospirosis. What are the signs and symptoms? Fever or hypothermia, cough with or without sputum production, can have hemoptysis, pleuritic chest pain, myalgia, malaise, fatigue. They may present with the GA symptoms, breathing difficulty, presence of wheeze, crepitations, can have a bronchial breath sounds, percussion node will be dull. And remember, symptoms may be atypical in an elderly individuals. You may not have a typical fever, cough, pleuritic chest pain, etc. in an elderly individual. It can cause presence with altered sensorium and chills alone. How do you diagnose? Etiological diagnosis, it cannot be determined on the basis of the clinical presentation. Lab tests are needed to establish the etiology. And why do we need a etiological agent? It allows the narrowing of the initial empiric regimen. So chest radiograph confirms the diagnosis of pneumonia, and it can assess the severity of disease and the presence of complications, and it could suggest the possible etiology depending on the infiltrate type. The typical chest X-ray shows a lobar pneumonia. Next is the sputum. Gram stain. Main purpose is to ensure the suitability of the sputum for culture. As I said earlier, it should be more than 25 neutrophils and less than 10 epithelial cells per low profile. Then only this suitable sputum for culture. And the gram stain may help in identifying the pathogens by their appearance. Culture sensitivity and specificity is highly variable, roughly around 50%. Greatest benefit is to alert a physician of an unsuspected cause or a drug-resistant pathogen. Blood culture, as only 15% of the cultures are positive. It's no longer necessary for all hospitalized CAP patients. Should be done in certain high-risk individuals, especially severe CAP, somebody with a coexisting liver disease, neutropenia, or asplenia. The blood culture positive organism, roughly 70% is pneumococcus, and around 15% is Enterobacteriaceae, Staph aureus, and 5% others. Other diagnostic tests, we have commercially available antigen tests, one to identify the pneumococcus, other one to identify the Legionella in the urine. The sensitivity and the specificity are high in both the tests. Can detect the antigen even after the initiation of appropriate antibiotic therapy, but the problem is the limited availability. Other rapid tests, we have a rapid test for the viruses. PCRs, it amplifies the DNA or RNA. Available PCRs, we have a PCR for Legionella, tuberculosis, and there are multiplex PCR detects the Mycoplasma, Chlamydia, etc. There's a PCR for available for pneumococcus also. What about the ATS, IDSA guideline for the diagnostic investigations? Sputum culture, 2019 guideline, not recommended in patients with recommended in patients with severe disease as well as in all patients empirically treated for MRSA or Pseudomonas aeruginosa. Blood culture, somebody who has a severe disease as well as who are receiving treatment for MRSA or Pseudomonas. Procalcitonin, It's not recommended to determine the need of initial antibiotic therapy. Steroids not recommended for CAP. What is the standard empiric therapy? We'll see it in the next slides. Site of care, you must make you consider the diminishing healthcare resources and rising cost of the treatment. Decision to where a patient should be managed is sometimes very difficult. The two important criteria are, one is the pneumonia severity index, other one is the curve 65. A PSI, it's a slightly has a longer list. You need to identify a lot of variables, roughly 20 variables, and you score it. It takes a lot of time, and based on the score system, you decide whether patient needs outpatient care, inpatient care, or ICU. The purpose of PSI is to classify the severity of pneumonia to determine the amount of resources to be allocated. Most commonly, PSI scoring system has been used to decide whether patients with pneumonia can be treated as outpatients or as inpatients. The easiest will be the curve 65 score. Only for C is for confusion, U for urea, or respiratory rate, BP, and age. So if the score is 0 to 1, then non-severe, around 2 is intermediate, 3 to 5 is severe. So 0, low severity, is likely suitable for a home treatment, whereas 1 to 2 is moderate severity, considered hospitalization. High severity probably require an urgent hospital admission, might require a ICU care also. There's another criteria by the ATS IDSA. It has got major and minor. Major criteria, requirement of mechanical ventilation, hypotension requiring vasopressors, minor respiratory rate more than 30, confusion or disorientation, hypothermia, hypertension requiring IV fluids, leukopenia, thrombocytopenia, and urea more than 20. So any of the major criteria, 3 or more minor criteria, patient requires an ICU admission. So all clinical prediction rules are supplements to the clinical judgment, which is of prime importance. If you feel that patient is sick, better to admit the patient. If you think the patient is more sicker, then probably the patient might require ICU care. Moving on to the treatment, the choice of antibiotic treatment is complicated by the emergence of MDR organisms in the community, and is dependent on various parameters like the likely pathogen, the resistant pattern in the community, the risk of antibiotic resistant in the patient. That means the prior antibiotic exposure to the patient, the severity of pneumonia, and the comorbid illnesses. There is a ATS IDSA guideline for the community pneumonia. When somebody does not have no comorbidities or no risk factors for MRSA or no risk factor for Pseudomonas infection, then amoxicillin or doxycycline or macrolide. Patients with comorbidities then might require a combination therapy with amoxicillin clavulanic acid plus a macrolide or a doxycycline. Or we can use a monotherapy with a respiratory fluoroquinolone. But since in India since we do see a lot of TB and drug-resistant TB, it's better to reserve the respiratory quinolones for tuberculosis. So we try to go with the amoxicillin clavulanic acid plus either a macrolide or a doxycycline will be the better option in our country. So, a patient in a non-severe patient, standard regimen, as I told, it's a beta-lactam plus macrolide, whereas patient had prior respiratory isolation of MRSA, then probably we need to add MRSA coverage. When somebody who had a risk of Pseudomonas aeruginosa infection or earlier isolated with the Pseudomonas, then probably he would require a anti-Pseudomonal coverage also. So other general parameters, adequate hydration, oxygen therapy, and assisted ventilation whenever is necessary. So not responding despite of appropriate therapy. Think about non-infectious causes, cancer, pulmonary embolism or hemorrhage. Think about a resistant pathogen, wrong drug or wrong dosage. Think about unusual pathogens, TB, anaerobes, viral or fungal. Then finally think about nosocomial superinfections. What are the complications of CAP? Respiratory failure, shock, multi-organ failure, bleeding tendencies, exacerbation of comorbid illnesses, metastatic infection like brain abscess, endocarditis, lung abscess, pleural effusions, which might require a diagnostic or a therapeutic tapping. Resolution of laboratory and clinical abnormalities. Fever usually settles down in 2 to 4 days at a time. Cough usually settles down 4 to 9 days. The lung signs 3 to 6 days. WBC count will promptly settle down in 3rd or 4th day. CRP will settle down in 3 days time. X-ray abnormalities will persist for a bit longer period, 4 to 12 weeks. Patient is considered to have responded if the fever decreases within 72 hours or there is the respiratory signs like tachypnea return to normal. So, thank you.
Thank you, Dr. Murli. So short and crisp presentations you made, but you elaborated all the risk factors. For example, you classified the pneumonia based upon the site, based upon the pattern, and based upon the environment where it's getting. And you also talked about the what are the risk factors for getting pneumonia also. And you touched upon the latest guidelines, ATS, IDSA guidelines, is 2019. What are all the diagnostic modalities we can use to make a diagnosis of pneumonia? Then you talked about touched upon the procalcitonin, because procalcitonin is one of the hot, as well as patients. You talked about where we can manage the patients of community-acquired pneumonia. And most important thing, when the person is not responding, what are all the signs of responding? What are all the signs of non-responding? And non-responding things also clearly mentioned about. Right now, a couple of questions has been posted for you. What are the audience is asking? Long-term complications of pneumonia. Can you elaborate what are the long-term complications? Consequences, not complications. Long-term consequences of pneumonia.
Generally, community-acquired pneumonia will not have any long-term complications once you appropriately treat. It will settle down. Untreated pneumonia or inadequately treated pneumonia only will end up in complications like lung abscess, sometimes empyema, etc.
Yes, I agree with Dr. Murli there, because pneumonia most of the time, particularly the typical pneumonia, most of the time the patients recover well. It is not like TB, or this is not like a systemic disease causing a bronchiectasis like pulmonary changes. Sometimes fibrosis, for example, COVID, following COVID, we have seen a lot of pulmonary fibrosis and interstitial lung disease patterns happen. That is seen in only selected patients. But cardiovascular events, up to 1 year, the risk of cardiovascular events can be very high. These are all the consequences usually we consider, both pulmonary as well as cardiac. But elderly people, again, the chances of getting fragility as well as cognitive decline, for example, dementia, people got forgetfulness like COVID, similar things we can apply for this pneumonia also. Our next question, Dr. Murli, what is the role of steroids in severe community-acquired pneumonia? They're asking about it there. Role of steroids in severe community-acquired pneumonia.
Yeah, a recent study which showed the usefulness of steroid in a community-acquired pneumonia.
They was asking about the dosing as well as durations. Role of steroids in severe CAP, dosing and duration.
I don't remember exactly. Dr. Suresh?
Yeah. The CAP study, like published in 2023 in NEGM, it showed 6% mortality benefit if you use hydrocortisone, 200 milligram per day. That means 50 milligram to 6 sali is the dose we're using for 4 to 7 days, not more than 4 to 7 days. It showed 6% mortality benefit, depends upon the CAP study. That if you apply the thing, nowadays for severe community-acquired pneumonia, not for mild pneumonia, This is for severe community-acquired pneumonia. We define the severity, what Dr. Murli has clearly defined in PSA scoring system. If we define severe pneumonia, you can use hydrocortisone 200 milligram per day for 4 to 7 days, minimum 4 days, go up to 7 days. The mortality benefit is 6% there. That's what the CAPCOT study published in 2023. He has shown 2019 guidelines, but in 2019 guidelines clearly mentions steroids has got very limited role. That's what, but the 2023, the publication has came, slightly people start using steroid, all because of the COVID, the experiences with COVID. And Murli, the third question is, how and when to decide on bronchoscopy?
Okay, bronchoscopy, when the patient clinically doesn't improve with appropriate and adequate treatment for at least for 72 hours, give a proper empiric treatment, and you are not able to get a diagnosis, get a microbiological diagnosis, then you can think about bronchoscopy.
I agree with Dr. Murli there, because he clearly mentioned what are the timeline for the person's responses. If the responses is not good, yes, we need to consider about it there. The next question is what to do when the patient is not responding to treatment and the sputum cultures are negative.
The answer was the previous one. You go ahead with the bronchoscopy and try to get the microbiological diagnosis.
Yeah. So correct. So we need to relook the diagnosis, whether our diagnosis of pneumonia is correct or not. If still considering pneumonia, we need to go for an etiological diagnosis. Most of the time, we don't think about etiological. But once the person starts not responding and the sputum, the initial test is negative, thinking about molecular tests or thinking about some invasive test to diagnosis, either histopathologically or microbiologically. But before that, think your differential diagnosis broad, whether it's pneumonia or something else you are doing it. When to suspect fungal pneumonia?
Okay, fungal pneumonia is not a common cause for a community-acquired infection, but you can suspect fungal pneumonia when somebody who is at risk to develop fungal pneumonia, like immunocompromised host, brings the HIV, and immunosuppressive drugs like post-transplant individuals, immunosuppressive drugs, diabetic patients, non-resolving pneumonia, in spite of adequate coverage. Those are the scenarios you have to think about fungal pneumonia.
I agree. The chances of fungal pneumonia in community-acquired pneumonia is very unlikely. He mentioned one entity called immunocompromised patients getting pneumonia. There, the threshold is a bit low to diagnosis fungal pneumonia. Not in the immunocompetent persons. We usually don't consider for a community-acquired pneumonia, unless we think the person has got a very good risk factor for pneumonia either. Then he is asking about vaccinations in young asthmatics or bronchitis. Which vaccination is advisable? Does yearly influenza vaccination has got any adverse effect if given every year for a long term?
Okay.
So what vaccination, asthmatic and bronchitis, and is there any impact on yearly vaccinations of influenza long-term consequences is asking?
Okay. Anybody who has a pre-existing lung disease requires both pneumococcal and influenza vaccine. Early influenza vaccine will not cause any long-term complications.
Yeah. We are given the vaccinations from 2010 when influenza pandemic started in 2009 and 2010. Ours is an adult vaccination center. We are giving almost 12,000 to 18,000 vaccines per day. But we have not encountered any long-term consequences of receiving every year vaccinations. And almost all the ID doctors, we are receiving the vaccinations every year. And we are not facing any long-term consequences of getting vaccinations.
Yes, you are saying that I've been getting the vaccine for the past 10 years.
Yes.
And in fact, if you look at the pediatric population, the incidence of the bronchitis is significantly less when you give a vaccination, a flu vaccine every year.
Can TB present as a cap and how to identify it?
Quite rare. TB is always a subacute disease. Generally, it won't present as a community-acquired pneumonia. Very rarely, whenever you have a immunocompromised host, can present with an acute, present as an acute disease, but generally in an immunocompetent individuals, it's quite rare.
Should both pneumococcal be given post-pneumonia episodes? And if you are planning to give both pneumococcal vaccines, how should the gap should be planned? What is the gap between the both pneumococcal vaccines?
Pneumococcal vaccine, you are talking about the conjugate vaccine and the polysaccharide vaccine. Correct. For immunocompetent individuals, it's 1 year. First give a conjugate vaccine, then after 1 year, give the polysaccharide vaccine. Then every 5 years, you repeat the polysaccharide vaccine. For a immunocompromised host, And those who have asplenia and all other risk factors, they should require, they will need give a conjugate vaccine first, then after 8 weeks, 2 months later, you give a polysaccharide vaccine.
So one question is I am not able to understand steroid used in strep pneumonia, anaphylactic cases. Okay, later we'll discuss it post-op. What is the role of vaccines? He clearly mentioning now. What is the role of vaccines?
Yeah.
In pneumonia prevention.
Okay. As I said on one of the slides, that a significant reduction of pneumonia in the infant or pediatric age group in our country, mainly because of the pneumococcal vaccination in the pediatric population. Similarly, the vaccination of the elderly and those who are at risk to develop a severe disease will reduce the incidence of pneumonia, community-acquired pneumonia.
One more talk about the same streptococcal pneumonia vaccines. He clearly told both the vaccines can be given. There's no contraindications after pneumonia. Fallacies of BioFire in CAP diagnosis, sir.
Okay, what I would say is don't use BioFire or any of the PCR from the sputum specimen. Go for a specific, probably a BAL specimen will be the appropriate sample to do a BioFire. If you do it BioFire in the sputum, then probably you will get a detection of multiple pathogens, then probably will be, again, will be in doubt whether to treat or not to treat. So generally, I won't do BioFire on a sputum specimen. I will reserve the BioFire for the BAL specimen.
Usually, the common one is available is upper respiratory tract respiratory viral panel test. It's useful during COVID time. Nowadays, we are getting a lot of mycoplasma pneumonia. So for upper respiratory tract samples, yes. Lower respiratory tract sample, usually we reserve for patients in ICU or immunocompromised patients we are receiving. But depends upon the clinical correlations. Yes, false positives can happen or multiple organisms can come up, but we need to go with the clinical possibilities. That's what we mean. Then people are asking about role of vaccinations in a smoker without COPD or without any other major risk factors, only smoker. Can we give pneumococcal vaccination to smoker alone without any comorbids?
I don't think smoking is an indication to give a pneumococcal vaccine.
One of the subtle indications we can put it like a smokers can receive. There's no contraindications. That depends upon the intensity of the smoking. How occasional smoker versus what is the intensity we need to consider about it there. Then people are asking about the again Prevnar 13 versus Pneumovax 23. What is the difference you are asking, or what is the timeline? You don't know. They mentioned Prevnar 13 or Pneumovax 23. You just elaborate what is Prevnar 13 and Pneumovax 23, Dr. Murli.
Okay. Prevnar 13 is the conjugate vaccine. Pneumovax 23 is the polysaccharide vaccine. Conjugate vaccine, it will give a long-term memory immunity, whereas a polysaccharide vaccine, it covers additional 10 strains. So generally, first you give the conjugate vaccine followed by a polysaccharide vaccine.
Yeah, basically one has got good memory like conjugate vaccines. One does not have a memory, but one has got a huge serotypes. That means 23 serotypes. Other has got only 13 serotypes. So both has got advantages and disadvantages. But fortunately now PCV20 is going to hit Indian market. That means only three difference. Only the difference is only 3 serotypes. That's going to hit 2026 or 2025 late part. And a couple of comments about BioFire is a very good in pneumonia. Yes, we agreed. But the thing is, it's not validated. Role of steroids, we told what is the level of inflammatory marker you're asking about it. It's not inflammatory marker. This is about the severity. We don't go with any inflammatory marker like CRP or procalcitonin or WBC count. This is a severity. The severity, one of the subtle clues clearly mentioned about in the pneumonia severity index based upon the thing. Then can patients initially manage with beta-lactam plus macrolide or doxy or beta-lactam alone for community-acquired pneumonia?
For empiric therapy, it's a beta-lactam plus macrolide or doxy. Which doxy or macrolide will cover the atypical organisms.
Okay, people are talking about the interleukin-6, whether interleukin-6 elevated needs steroids or not. In COVID time, we have used interleukin-6 as a criteria. But so far, my knowledge goes, there is no study evaluated in community-acquired pneumonia, role of IL-6 based immunosuppressants. What the CAPCOT study showed, depending upon the severity is defined by the standard criteria, what Dr. Murli has alluded there. So not because of the CRP or ESR. initially told development, but off late we are seeing a lot of mycoplasma pneumonia in the last 3 to 6 months. So beta-lactam alone is not going to solve the problem. Western world, if you read the guidelines, fluoroquinolone also they mention about it, particularly later generations fluoroquinolone. If you use later generation fluoroquinolone, there is no need for atypical cover because it has both typical and atypical. But unfortunately, in India, levoflox is a good TB medicines. So invariably, as agreed with Murli, we need to use both beta-lactam antibiotics plus or minus macrolide. That depends upon the situations. Last 3 to 6 months, lot of mycoplasma pneumonia is surrounding, and mycoplasma pneumonia azithromycin resistance also we are noticing. That's a problem there. So that's why we want to use it there. Okay. Sputum KOH mount, if positive, should be treated.
Yeah, if it is a yeast-like organism, then definitely not to treat. Canada will never cause pneumonia. Then if it shows the filamentous fungi, then probably depends on the risk factors you have to decide. Yeast, definitely no treatment.
It's very good, valid point. That never treat your candida in the sputum cultures or bowel cultures also. Never treat candida. Candida never causes pneumonia in immunocompetent host. Only selected situations as an ID specialist, only a couple of situations only we used to treat. But for practical reasons, candida growing in bowel, candida growing in sputum, ED, never treated. And KOH smear, rightly pointed by Murli, depends upon the comorbid conditions. What is your diagnosis? What is your pretest possibility? Chances of fungal pneumonia is there, then KOH shows some septate or aseptate, then depends upon the host factors decide about it, but do not treat candida. When will you hand oseltamivir in your practice, Dr. Murli?
Okay, if the clinical presentation looks like a viral, for example, presenting with the upper respiratory symptoms, running nose, nasal, stuffiness, throat pain, then fever, myalgias, arthralgias, then probably I'll go with the oseltamivir. When there is no symptom suggestive of viral infection, then probably doesn't have any role.
CAP in HIV patients, Murli's favorite topic.
Again, in HIV, again, pneumococcus is the most common cause pneumonia, 200% risk to develop pneumococcal pneumonia in HIV. Still, even in HIV, CAP, pneumococcus is the commonest organism. Then, depending upon the immunity level, the CD4 count, and you have the list of bugs causing lung infection. Then, based on that, plus the clinical presentation, we need to decide the treatment.
Somebody said not able to be the slides, but we are getting the presentations, whatever presentations they want to share with the students, we are getting it after the talk, and we try to put it, and we are writing up also this. So don't worry about it. We'll get the slides from the faculty. So those who are not able to visible or not joined little late, definitely we are providing the content to you, because 130 minutes we can't teach entire pneumonia there. This is only a tip of iceberg what we are teaching. People asking about dose of Ceptron in
Pneumocystosis. Okay, it's a 10 milligram of trimethoprim. Basically, rough doses will be every 10 kg you use one double strength tablet. For example, somebody 60 kg, it's 6 tablets a day, 222. 70 kg, 7 tablets, 322. 40 kg, 202. Every 10 kg, one double strength tablet. That will be a rough guide.
Thank you, Murli. This is the last 7 to 8 weeks. This is the maximum number of questions we received from the participants. I thank you because of your initiative of doing a wonderful presentation that made participants to ask, keep on coming there. So, but this is the maximum number of questions we received so far in the 7 to 8 presentations there. Recently, we had an outbreak of what do you call CRF and STP?
CRPF or STP, what are used in irrigation hemorrhagic? No.
CRPF. What is it? CRPF?
Okay. CRPF personnel, police personnel.
Okay. CRPF and STP. Water was used.
I implied had hemorrhagic pneumonia. We isolated influenza A, entero, rhino, and biofair. Just
okay. So multiple organisms in biofair. What are you going to do?
Okay.
Multiple organisms comes in biofair. How will you react?
See, that's the problem with the any PCR test you do. So we will have a polymicrobial detection. Then we won't be knowing which one is the causative organism, whether this is the causative organism or something else is causing. It depends on your like clinical presentation, your radiological findings, everything. Then you decide about whether to go with this biofare or not.
Yeah, fortunately, this case influenza, entro and rhino. Entro and rhino does not have any treatment, so treat only influenza A. That is most likely because entro and rhino we can't give any support there. Regarding the role of galactomannan and beta-D-glucan test.
Okay, galactomannan, whenever you doubt aspergillosis, invasive pulmonary aspergillosis, you can do galactomannan and use it as a preemptive treatment. BDG, yeah.
For a PCP, we use beta-D-glucan. It has got very good negative predictive value and similarly very high PCP value in HIV patients. Yes, otherwise beta-D-glucan in pneumonia has got very limited role. Candida will be able to pick it up. It pick it up PCP there. So if you think PCP and HIV patients, if you don't have any other test, do beta-D-glucan. The beta-D-glucan is normal. It essentially rules out PCP. If it is elevated, very high value, think of PCP or PJP we call nowadays. That's a possibility. Otherwise, galactomannan, Murli has answered this one. For patients with immunocompromising conditions or risk factor, that is a good test for fungal pneumonia. Again, all has got negative predictive value is good. If it is normal, rules out. Presence of high value, always take with pinch of salt, depends upon the clinical situations. For step pneumonia, sputum culture is proven. Is culture negativity demonstration is sputum required? Whether we need to demonstrate sputum negativity after treating the patients?
No, definitely not needed.
Yes, agreed. So I sincerely thank Dr. Murli for spending valuable time and getting maximum number of questions so far in the presentations. In short notice, we start preparing. Usually at the end of the presentations, we make we do one presentations to check the post-test of the students there. I just start sharing my post-test questions right now. 1 second. Yeah. The last 10-15 minutes we keep for the post-presentations there. So already Dr. Murli touched upon all the slides. We're just going to make a quick summary. What people who joined little late, just get the tip of the iceberg. Usually this is a post-test. So people need to answer. Don't think you just put your name in the chat box, you'll get the attendance for today's class. You need to answer this question so that you can get a attendance. That's the usual trend in certificate in short certificate course in infectious diseases. Not typing your name, you're not going to get the attendance. You need to answer this post-test so that you can get the attendance. So 38-year-old female, diabetic from southern Tamil Nadu, fever of 7 days durations. She got headache or shortness of breath of 5 days durations. On examination, the patient is confused, febrile, tachycardic, tachypneic, hypotensive. On examinations, crackles were hearing, WBC count was elevated, polymorph predominant with slight decrease in platelet count. Elevated bilirubin, elevated alkaline, elevated ALT, SGPT. Creatinine was also gone up. X-ray shows bilateral infiltrate. Does this patient have got pneumonia? Yes, no, maybe. Start antibiotics. Wait till my next slide then. So how many people are answering? I just want to check. So please go ahead and answer so that we can have a discussions about the thing. Okay. People say yes. People say yes and start antibiotics. This is pneumonia only. Don't wait for it then. Don't make diagnosis, start antibiotics. Couple more seconds. People asking malaria test. Malaria negative. Okay. So most of the people start answering. Those who are not answered, please clicking the answers so that we can check your attendance later part of it. So usually the diagnostic dictum in infectious diseases make a syndromic diagnosis. What is a syndromic diagnosis for pneumonia? Dr. Murli clearly alluded. Fever, cough, chest pain, shortness of breath. In presence of fever, cough, chest pain, shortness of breath. Some of the atypical manifestations also outside the lung is also possible. But to make a pneumonia syndrome, these 4 symptoms should be present. So this is an ideal. If all 4 is present, the sensitivity can go up. And this is a beautiful JAMA paper. You need to read about it. When a patient comes to you in front of you, we need to ask whether this patient has got pneumonia. I told them presence of fever, cough, shortness of breath, chest pain. But the presence of all the symptoms and signs, all the symptoms, whatever I told, fever, cough, shortness of breath, along with chest pain. If you do a auscultations, crackles, particularly presence of crackles or wheeze or decreased breath sounds or bronchial breath sounds, despite all the clinical parameter, the sensitivity is almost 50 to 60% only there. The sensitivity crosses maximum 70%. The specificity is also not great. Then why we ask the thing? If you ask all the symptoms and signs, the chances of sensitivity can go up. All the signs and symptoms are absent. It has got very good negative predictive value. For example, the person does not have fever, cough, shortness of breath. The chances of pneumonia is less likely. So it has got very good negative predictive value. Presence of symptoms, more symptoms, the sensitivity and specificity can go up. So this is the questions we need to ask. And this is one of the beautiful references you need to go and read. Test these patients have pneumonia in JAMA 1997 paper. This is very old paper, but it's very valid paper. So this is each signs and symptoms, what the likelihood ratio of pneumonia. If fever is present, what is the likelihood? If the fever is absent, what is the likelihood? Usually all the things is negative, the likelihood is very less likely the person has got pneumonia. So coming back, what is the etiology? People say this is pneumonia. So what is the etiology you think about it here? The patient's sputum is grown yeast as well as pseudo-hyphae. People talk about community-acquired pneumonia, yeast and pseudo-hyphae is seen. So what do you think? This is candida pneumonia. People start answering so that we can discuss. Or viral pneumonia, bacterial pneumonia, viral plus secondary fungal plus bacterial, polymicrobial. So please go ahead and answer. So first thing we talked about, when to think about pneumonia, presence of signs and symptoms, the chances are a bit high. Absence of signs and symptoms rules out. People took multiple choices, 2, 3, 4, viral, bacterial, antibiotics, giving a lot of choices, viral pneumonia only. People are ignoring them. The point is well taken. Dr. Murli has conveyed the message, community-acquired pneumonia, even if the yeast is present, even if the candida is growing, it is not fungal pneumonia. The point he conveyed very clearly, this is a community-acquired, no major risk factors apart from the diabetes. So the chances of fungal pneumonia in a community-acquired presence, and particularly yeast is growing in the sputum, it has got very, very, very limited. There's no role, not very limited role. No role I can put it right now. So I don't want to tell the patient has got some role. It has got no role to me. And he clearly told what are all the pneumonia organisms. We usually call 3 typical organisms, staph, strep, and H. influenzae, and 3 atypical organisms, Chlamydia, Mycoplasma, and Legionella. These are all the 3 atypical organisms. Our organisms should be staph, strep, H. influenzae, then Chlamydia, as well as strep, Mycoplasma, and Legionella we need to cover. But the problem in Indian scenario, problem in Asian scenario, we usually get some other organism. That's the problem. So what are all the some other organisms? We are getting a lot of leptospirosis is possible, scrub typhus is possible, milioid, but milioid is subacute, not a community-acquired acute pneumonia. But sometimes the person does not recognize the symptoms and present acutely towards the end is also possible. And tuberculosis, he clearly told acute pneumonia, TB is less likely, but when the person does not recognize the symptoms, subacute or chronic, suddenly make acute presentations, think about tuberculosis also. So the differential diagnosis of pneumonia in Southeast Asia is more compared to standard thing what you mentioned about it. So always think about leptospirosis also can cause pneumonia. Scrub typhus is also causing pneumonia, apart from the standard organism. That is what is mentioned clearly. So don't think always that pneumonia reads a textbook and come to the patients. Keep in mind. And this is TB endemic country. Usually acute presentations, we don't think tuberculosis is a possibility, but depends upon the history, depends upon the presentations. Usually subacute to chronic, and the symptoms lasting more than 10 days or the symptoms lasting more than 14 days, or the person responding, particularly people put levofloxacin, copying the Western guidelines, put levofloxacin or putting linezolid. The person start responding well. Again, the symptoms reverting back. Think about tuberculosis. Because levofloxacin, linezolid are good second-line TB drug. Person improving and getting back, think of TB. These are all the situations we need to think. Or the person is not responding, cavity type of pneumonia, upper lobe, poorly controlled diabetic, some steroid intake, we need to think about our family history or close contact. That is more important. So we need to think about TB these situations. And this slide, Dr. Murli has alluded, so I don't want to repeat. Some of the urine-based tests also, for example, antigen-based tests, step pneumonia and Legionella pneumophilia, we can able to find out, but the sensitivity is not great. And similarly, PCR, what he alluded is called multiplex PCRs, point of care. But pneumonia panel, one of the participants has talked about it. The pneumonia panel is very good. But unfortunately, the validation is not done properly compared to the upper respiratory tract. For example, the throat swab for RV panel well validated. Pneumonia panel by this one is not that much validated. So we are little hesitant to use. What is the difference between this one and the lower respiratory panel? This picks more of viruses. Lower respiratory panel picks more of bacteria. But the point is clearly conveyed by one of the participants. Resistance mechanisms also picked up in pneumonia panel. That is very advantage for us. So the diagnosis guideline Dr. Murli touched upon, and no need to touch about it. He clearly shown the table. Then sputum and blood cultures. The yield of blood cultures in community acquired pneumonia is not great. So if you send a blood cultures, don't expect the report will come back positive. The yield is hardly 7 to 10%. When the person is sick, shock, ICU, you are thinking about milioid, the chances of picking up is very high. But when the person is in community acquired, coming to the OP with the curve score is very less, the chances of picking the bacteria in the blood is very less likely. Particularly step pneumonia is very easy to kill. Even 1 dose of amoxicillin or 1 dose of whatever antibiotic, step pneumonia cannot grow, because that is one of the commonest cause of pneumonia. Very easy to kill also. So don't expect community acquired pneumonia. The blood culture will have growth. So this is a case he clearly mentioned where you want to manage. This is again a clear post-test questions. I expect participants to go ahead and answer where you want to manage this case. I'll wait for 30 seconds people to answer. I like to see the responses. People want to manage 3 and 2. So 3 means the person want to ICU ward. Some people say I can manage in the ward, depends upon the cost. So I think people who answer only get the attendance there. So only few people are answering. Yeah, good. Ward versus ICU, very good. So he clearly mentioned about these are the 2 criteria. The simplest criteria is curve 65. Anybody can do the calculations. This is little complicated one, but nowadays we are putting curve 50 because above the age of 50 is a risk factors for pneumonia, not necessarily 65. Even above the age of 50. That's why the recommendations for pneumococcal vaccines previously 65. If you read the latest guidelines, 50 is a criteria to start pneumococcal vaccinations. So we can put instead of curve 65, curve 50, I can put it. And this is an IDSA, ATS guidelines. This is valid because PSI is a bit difficult to calculate, very difficult to calculate. This is little easy. When a person requires ventilation, just necessarily ICU. When a person in shock, we need to ICU. And these are the 3 criteria, minor criteria. Whether the person is tachypneic, hypoxic, multilobular infiltrate, new onset confusions, uremic, leukopenic, thrombocytopenic, hypothermic. All the criteria, minor criteria, is fitting into this case, so he needs to go to the ICU. That's the point we are conveying here. And this is one good paper recently published in NEJM. We are giving recent update also. What is the pathophysiology of pneumonia? Usually we need to read about it because basically this is aspirations or the presence of the bacteria in the air, or some of the bacteria can colonize the respiratory pharyngeal tracts. Micro aspirations can lead to. And what is the defense to prevent, and what are all the defense mechanisms lacking also mentioned about it. So I think this is the last questions to test post-test. What antibiotic will treat for this person? Please go ahead and answer so that you can get your full attendance here. So people are answering 3. Choice 1 plus doxycycline. Amoxicillin plus doxy. People say amoxiclav plus macrolide or doxy. Okay. 6. Meropenem plus vancomycin. Please answer. Go ahead. I'll wait for 10 more seconds to close the thing. So all the things what Dr. Murli has discussed today, we put it in the post-test. So people got the grasp most of the things. That's a good news there. So you're answering also, that is very good. And people are still attending the session. 96 people still awake there. And this guidelines, Dr. Murli touched about it. Non-severity versus severity based upon the risk factors. So this is a classic guidelines. He mentioned about it. And this is a CAPCOD study, what you are asking about it. This is a CAPCOD. Depends upon the severity. It not depends upon the inflammatory markers. 200 milligram per day, we can use it. And this is when to consider MRSA agent, when to consider Pseudomonas agents. Clearly, it mentioned about it. Antibiotics in the past 60, hospitalizations and residents in a nursing home or small nursing homes, you can put it here, and family members. When to suspect TB, people are asking about it. Usually the cough lasting 2 weeks, not acute presentation. Murli clearly answered this one. Not for acute presentations, subacute presentations. Think about it. Think about weight loss, cough hemostasis, or upper lobe infiltrate, or miliary pattern, or cavity lesions, or nodular infiltrate. responding to levofloxacin, linezolid, moxifloxacin, think about it. Getting back again. And think about this is also, people ask whether I need to use macrolide or doxycycline, a lot of controversy as an add-on therapy. Usually we prefer doxy of late. Why? Doxy is a better drug for scrub typhus. Doxy is a better drug for leptospirosis. Doxy is a better drug for mycoplasma pneumonia also. So if you want to add a second line drug, macrolide, instead of macrolide, the macrolide resistance is also growing up. Instead of a macrolide, use doxycycline along with your beta-lactam antibiotics. Particularly the patient has got a risk factors for either milioid or leptospirosis or scrub typhus. Then one more thing is nowadays short is sweet. As far as community acquired pneumonia, the duration is 3 to 5 days. People never use 3 days, but 5 days is okay. The person in the ICU or what 5 to 7 days, unless some complications, what Dr. Murli alluded, parapneumonic effusions or some complications, sepsis formations, we need to treat longer. Otherwise, 3 to 5 days is enough. That's more important. Short is sweet. We are not told. Alexander Fleming itself told. So this is a randomized control trial. 14 trials showing community acquired pneumonia, 3 to 5 days is fine. So the very last questions, what is the answer to these questions? Examine the patients. Instead of asking for a biofires, instead of asking for a blood cultures, go back and examine the patients. We found a beautiful HCAR in this person's. So community acquired pneumonia in India, these cases, leptospirosis, scrub typhus, milioidosis, think about it. Examination is more important. So don't think always I want to do the biofire, I want to do the CT checks, I want to do blood cultures, I want to do antigen-based tests, I want beta-glucan. No, this is a simple things you can do. You can able to get the answer if you spend time with the patients. So you can find out. So pneumonia is common. Detailed history and vital examination is needed. In Indian subcontinent, think some rare diagnosis like scrub and leptospirosis, not mentioned in Western guidelines. Doxy is preferred nowadays. 3 to 6 months, we think about doxy, not only for scrub, lepto, for mycoplasma also. Short is sweet, particularly for pneumonia, short is sweet. 3 days is enough, or maximum 5 days is good. So these are all the key points what Dr. Murli clearly alluded. Whatever point he tested, we put a post-test. I hope most of the people participated today and got the attendance also there. And these are all the algorithms is coming up, a lot of algorithms. When to think fungal pneumonia, when to think community acquired pneumonia. We need to divide mild versus moderate and severe, and what antibiotic, what test. A lot of guidelines is coming up. These are all the study materials we are going to post to you. Please read about these guidelines and read about, if you're not able to read, you're not able to attend the things, the conference is coming up. Please register for the conference. We are discussing only algorithms, like the algorithm what I shown just now. For pneumonia, the algorithms is coming up. Similarly, all the diseases, fever with rash, fever with the diarrhea, fever with altered mental status, all events are going to discuss on the last week of April this month. Please register and scan this QR code, and you can register for this conference and learn a lot. I sincerely thank again API for giving this wonderful opportunity, and ICP for giving this opportunity. And my sincere thanks to Dr. Murli for spending time and getting maximum questions from the participants. And I thank the participants and answering actively and stay till the end of the time, till 1 hour sessions of 90 people are staying back. Thank you very much. Any questions? Last couple of minutes for the first there. So we want to finish on time. Last couple of minutes there. Any questions, please shoot. Kamlesh Tiwari sir, if you joined, your words of wisdom also, sir. Not able to check whether it joined. Tiwari sir, please sir, join. See the name of Tiwari sir. Please join. Any questions? Couple of minutes. I think a couple of messages has come back. I need to check. One more question. Can the search? Can the season, summer or winter, help us in identifying the clues to the fever etiology? Yes, definitely. Particularly in the winter season, Murli alluded about it. For example, the leptospirosis, scrub typhus, milioidosis, these are all post-rain. In fact, in 2015, Chennai rains, when Dr. Murli was here. So we see a lot of milioid. People expected leptospirosis after Chennai floods in 2015. But what we saw is a lot of milioidosis emerged in 2015. Definitely following the climate change, particularly the winter seasons, we see a lot of, particularly the time for scrub typhus is between August and February. Similarly, we see a lot of leptospirosis after the monsoon season, and milioidosis also we have seen a lot of questions, a lot of milioidosis we have seen. In fact, one of our colleague has published a paper in 2015. A lot of milliardosis happened in 2015 floods. You can read that paper also. If no more further questions, it is 8:30. Thank you. Thank you all the participants. Thank you, Dr. Murli, for joining today.
Thanks, Dr.
Very
Suresh.
good.
Bye-bye.
Thank
Good
you.
day.
Bye-bye. We are closing the session now. Thank you.